related TMA. The cases will be presented by Dr. Rimda Wanchoo. She is a professor of medicine at the Zucker School of Medicine, nephrologist at Northwell. She is an associate editor of Journal of Onconephrology and Clinical Kidney Journal, and one of the founding members of the American Society of Onconephrology. And Dr. Kenar Jhaveri is a professor of medicine and associate chief of the Division of Kidney Disease and Hypertension at the Northwell at the Zucker School of Medicine. He is co-director of the Glomerular Center at Northwell Health and also fellowship director for Onconephrology and Glomerular Disease Fellowship. Of course, founding member of the International Society of Glomerular Diseases. His passion is also medical education. You all have read the Detective Nephron series, and probably everybody has the ASN Kidney News on their kitchen counters. The next expert is Dr. Ilene Weitz. She is professor of medicine at the Keck School of Medicine, the University of South California, in the Division of Hematology, and she's kind of been a legendary expert in any complement disorders, and is kind of well known for interest in various complement disorders.
All right, so we'll start with the second session. These are the disclosures. And I'd like to acknowledge our two nephropathologists who are probably remote right now, but Dr. Yang and Dr. Lytle, who served us with the pathology slides. I'll start with the first case. It's a 55-year-old woman with a history of hypertension, multiple myeloma, who underwent autologous stem cell transplant on maintenance therapy with daratumumab, steroids, and carfilzomib, who presented to the ER. She endorsed dyspnea, fatigue, diarrhea, and vomiting, and had been diagnosed with COVID-19 just about 2 weeks prior to the presentation, and had sort of recovered from it, but had a little bit of cough still. And review of systems is as above, and these are her home medications. And just a little bit about the myeloma history, because I think it's pertinent to the case. In February of last year, in 2022, she was diagnosed with IgG kappa myeloma. From March to September, she had completed 6 cycles of bortezomib, lenalidomide, and dexamethasone induction therapy, followed by an autologous stem cell transplant. Post-transplant, she still had an M spike, as you can see, and her kappa lambda ratio was at 35. March through May of this year, she continued to have some measurable disease, and she received maintenance therapy with bortezomib and lenalidomide. Her blood work revealed the light chain still sort of increasing. The ratio went up from 39 to 68, at which time she was changed to daratumumab as well as pomalidomide. Finally, pomalidomide was stopped and carfilzomib was started in July. So when she came to us, which was around August, she had been on the 2nd cycle of the carfilzomib and 8th cycle of daratumumab. Physical examination, just significant for hypotension and bradycardia, and just appeared a little sick, but nothing else. And these are her labs. She came with a hemoglobin of 7.9. Her platelets were suppressed at 20. Profoundly hyponatremic, hyperkalemic, and in severe AKI with a BUN of 160 and a creatinine of 12. Calcium was low, the phosphorus was 9, and the uric acid was 12.8. About 10 days prior to presentation, she had completely normal kidney function. And these are her other labs. Her stool did grow some enteropathogenic E. coli, not the Shiga toxin. Her LDH was elevated at 1717. Her hapto was less than 20. Her M spike was about 1.2 grams. It was similar to what it had been for a couple of months prior to presentation. And this is the IgG kappa, which you can see, again, sort of stable to maybe stable, I would think. And her kappa lambda ratio was at 33, and it was 54 and 68 in the months prior. So what do we think is the cause of her AKI? Do we think she has tumor lysis? Does she have a TMA? Does she have acute tibia injury, or does she have all of the above. And would you do a kidney biopsy, yes or no?
Wait, yeah, well, the next first. The next question. Okay, that's
Yeah. So nobody thinks it's tumor lysis? No, okay. So I guess it's a TMA conference, so most people think it is TMA.
There
Yeah.
are a few who answer all of the above.
Yeah,
so
there are a few
is some-
people who did say all of the above, which I guess is.
I
We'll
mean, the
see.
labs fit for tumor lysis.
Huh?
The labs fit pretty
The labs
classic for
fit.
tumor
So
lysis.
that's what we said. It could be some TLS, it could be some ETN, some
All
TMA.
of the above are including tumor lysis.
Yeah, it includes
Yes.
everything.
Yeah, okay.
Yes, yes, it includes TLS, yes.
All right,
So,
the next one. And so the question is, would you do a biopsy in this patient?
her platelet counts were low, but all right, I mean, sort of split, 50-50. Yeah. It depends on where you are. If you're in Northwell and Kenar is on service, you will biopsy. It's like not even a question.
Just give platelets and biopsy.
I know. All
DDVP.
right. So I guess more people are being more conservative, and I think
You know, Jeff Lawrence is a big proponent of skin biopsy
skin.
as an easy, less invasive way of identifying TMA because it's a systemic process.
True.
But especially if you have a necrotic area on the skin. But you could do a skin biopsy, you could do a gingival biopsy for that matter, and probably see the TMA.
So even if your skin is
Yeah,
otherwise okay,
yeah.
you don't have any manifestations.
He has a lot of experience with it. I don't. I have some experience with it, but he's a really big proponent of it.
Okay. Yeah, that's great. So I guess we did biopsy her, but in all fairness, we biopsied her a little bit later in the clinical course when things were better and the platelets were safe. And this is a light microscopy, and I don't know if you can see, but she had some focal duplication of the basement membranes of the GBM over here. And this on the right side is a slightly a glomerulus showing some hypoperfusion and some ischemic wrinkling of the glomerular capillary wall. This is the immunofluorescence, positive for IgG, as well as slightly more predominant for kappa. And this is the electron microscopy, which basically shows endothelial injury and duplication of the basement membrane along with expansion of the subendothelial space with some electron-lucent material. And her pathology report was read as chronic active endothelial injury and repair, best classified as thrombotic angiopathy with severe and diffuse vascular involvement, including extensive sclerosis of the arterial and the arteriolar wall with widespread endothelial injury and remodeling of the glomerular capillaries. The background staining of the tissue being stronger for kappa as compared to lambda was most likely a reflection in the tissue of kappa restricting, is that a circulating monoclonal immunoglobulin or the abnormal free light chain ratio. And the biopsy did not show any lesions of amyloid, light chain cast, or light chain tubulopathy. And there was some evidence of acute tubular injury, which was sort of recovering. So what do you think is the cause for her thrombotic microangiopathy? She has the multiple myeloma. She was on carfilzomib. She had had the COVID infection, and she was also on daratumumab. Okay. So nobody thinks it's the COVID. I guess in 2023 we don't really see that much of COVID-associated TMA. I guess we did see it in 2020, but I don't know if it's the virus not being as
There we go. We have two people infected.
oh, well. It's okay. So most people do think it's the carfilzomib. So would you do any additional testing at this point? Okay. So what would you do next? You have a patient who's got severe AKI at this point. You have her with anemia, thrombocytopenia. Okay. So most people would stop the carfilzomib, and a few people would stop and start plasmapheresis. Some would start eculizumab. Well, okay. So this is split. So most people would stop carfilzomib,
What
but
about
half
those
will
who thought
start and
DARA-
half will.
Some people thought DARA was the cause, right? They want to stop the DARA. We also had a choice for, no? Nobody wants to stop it? Go ahead, Rimda.
Okay.
Well, I think you need to look at whether or not the patient's having a response or not. If the patient's getting better with the drug, well, if you can stop it, but you know the patient's going to get worse, and so you may want to intervene with something such as eculizumab, which might allow you to continue treating.
Right.
And I think that's an important thing. Most of the data, which I'll show you later, is retrospective. So there are no prospective trials.
I mean, both myeloma or paraproteinemias and carfilzomib have been associated with thrombotic microangiopathy. So it's not a very easy decision, especially because the biopsy also showed monoclonality and thrombotic microangiopathy. So is it the myeloma that's driving the endothelial injury, or is it the myeloma is just stable, and is it carfilzomib that's driving the endothelial injury? I don't think it's DARA. I've never heard of DARA causing endothelial injury, but that doesn't mean it doesn't happen. It's possible, but it's going to be very hard because you have a disease and the treatment both linked to endothelial injury.
And the patient had been switched to this therapy after going through a few different therapies, right?
Yeah,
While she was not responding to the
Right,
previous
so the
ones?
carfilzomib is typically, and I think Dr. Weitz can correct me, but it's typically third line or something, right? It's people who are not responding to
Yeah,
the traditional,
pretty much.
and then you're getting on to this drug. Does the fact that she had completely normal kidney function 2 weeks prior, and at that time had similarly, her M spike and her light chains were in this range 2 weeks ago also, and does the acuity of her presentation lean you towards one versus the other?
Well, she's the one who was positive for Shiga toxin.
No,
negative.
Was she the one?
No, enteropathogenic.
Oh, okay. So, I think the acuity of it lets me think that it's probably drug-related. Yeah.
The other clue, I think it's carfilzomib, is the tumor lysis-like presentation. That has been linked with proteasome inhibitors. So it's possible that initially there was a tumor lysis-like pathology, and underlying there was TMA as well. And there's some thoughts that TMA is the pathology of tumor lysis syndrome. In the recent Jason paper, it might be actually endothelial injury that happens in tumor lysis syndrome.
Interesting, yeah. Okay. So we thought that it was TMA secondary to carfilzomib and acute tubular injury, and I think for the reasons just discussed, we felt that her myeloma had been sort of stable. The drug was relatively new, and the drug has been associated with the TLS and TMA also for that matter, and we thought it was probably that. So the patient follow-up, she was initiated on CRRT because, as I mentioned, she had a potassium of 8 when she came in, and she was bradycardic. So, and because her plasmic score was 5, which was consistent with intermediate risk, and there was this sort of concern that this could be TTP, She originally, as she admitted, she was started on prednisone along with plasmapheresis. She had received 3 treatments. Finally, her ADAM TS13 came back at 35%, and we stopped the plex. And she was started on treatment with eculizumab. And this is her most recent kidney function. Her creatinine has completely normalized at 0.6. Her LDH is down to 350. And this is about, she started showing some recovery of kidney function about a week after starting eculizumab. And these labs are about 2 weeks post-eculizumab.
So a week for kidney function, Rimda? Took about a week?
To sort of improve.
To improve, not
necessarily
normalize.
come off dialysis, but not completely normalize. It took a little bit longer. Yeah. Yes, so here it is. Actually, we had wanted the complement testing to be done prior to the initiation of eculizumab, but it was, drawn about a couple of days after. So you can see some activation of the MET.
Despite that, Sangeeta, it bothers you, right, that she's been on, this is if this was after ECU, and you're looking at C5b9 after that. So that's...
But it's about a day or two after.
just a day or two, that's right.
Not that long, though, yeah.
Okay.
So I guess you sort of answered this question. This was for the panelists, that how does one differentiate paraproteinemia versus a drug-related TMA?
Yeah, it might be worth repeating that. I think there were several people who answered that if they thought it was myeloma-related, right? So just some quick...
The myeloma, so again, the kidney biopsy did show, so if this was a pure TMA from myeloma, you should not see monoclonality on the biopsy. It would be, IF would be negative. The immunofluorescence would be negative, and it's just thought that the light chain triggers endothelial injury, and you get TMA. If this was carfilzomib, pure TMA, you wouldn't see, again, immunofluorescence would be negative. But here, because perhaps the myeloma was so active for so many years, and there have been a lot of drugs tried, maybe there was some deposition disease to begin with at baseline, but not causing her AKI, because that would cause more proteinuric disease. And so I think here, given the pathology of TMA was more active and new, and ATN was new, I think that's carfilzomib related. I mean, based on my reasoning on that.
I agree with that. I think the fact that she had active disease at the time that she was biopsied could account for the clonality in the kidney. So I don't think that rules that states that it has to be myeloma causing the disease. Whereas the drug was new, and there was a rapid change in her renal status and everything else, and TMA. So I think that it's really consistent with a drug-induced.
So more the time frame and how the clinical picture presentation.
Anisha?
Yes.
Hi. Yeah, I think, looking back at this case, at the beginning it might be very hard to say which one caused which, because both of them can cause the TMA picture. But when you look back at the clinical, how the patient rapidly improvement, and the fact that, the TMA, if it is associated monoclonal, we didn't treat the clone, why, the patients get better.
True.
So it kind of, suggesting toward this is perhaps the drug more than the other, because the clone is still there, and if it is indeed from the clone, why the patient get better.
So you're saying while the myeloma was kind of responding, her numbers were worse? Is that what you're...
Well, so when the patient came in, it looked like the kappa was better after carfilzomib was started, but, the carfilzomib was stopped, and then the patient's getting better.
Yeah.
So if it is indeed from the clone, then why is it get better? Because the clone should rise, right? With the holding the
Do
treatment.
you know the half-life of Kyprolis, or like...
Carfilzomib?
I believe it's like less than an hour or so, right? That's what
It's really short.
It's really short, yeah.
So you should see immediate effect when you're pretty quickly, maybe, I guess.
I mean, I thought that maybe also the fact that she had some ATN, that probably got better with time. It was, I think the remodeling that was seen, I don't necessarily think that is 100% consistent with the creatinine of 0.6 right now. I think this is a woman who might end up with some more chronic changes over the years, but at least right now, I think some of the AKI was probably ATN, TLS also.
One of the things here is that we talk about plasma half-lives, but there are biological effect half-lives too,
Much
which are going to be much longer. So
Yeah.
I think we got to be very careful here because
True.
these are very dirty patients
Yeah.
in that sense, because you're trying to make up a story based on multiple snapshots. And I'll be careful there,
Absolutely.
because if the tumor's getting better, the tumor's getting better.
True.
I've got a question about the EGG kappa deposits on your kidney biopsy. There is double contour formation suggesting that the biopsy was done after a couple of days of the TMA. So probably it can be eculizumab that you are seeing, the IgG kappa.
So the biopsy was done probably almost 2 weeks after the eculizumab, 2 to 3 weeks, yes.
Okay, so that can be the
Maybe.
drug that you are seeing right there. Yeah.
Isn't eculizumab a lambda
Oh, you mean?
No, IgG4, IgG2 kappa.
or kappa? Okay.
And the subclasses should allow to differentiate exceptional deposits versus...
Yes, you can.
Yes.
Might be too soon though.
If you perform the IgG subclass staining on the kidney biopsy, you will see IgG2 and
True.
Stand
IgG4.
for IgG4.
Yeah, you can stain for IgG4.
What I found a bit puzzling, this is a great discussion, and thank you very much. What I found a bit puzzling is the fact that the acute kidney injury was very, very acute within a few days, while the pathological features were more chronic, like this kind of chronic TMA, you see, with the MPGN pattern, double contour, and so on. So that's a bit puzzling.
True.
Comment.
I mean, she had been on other proteasome inhibitors also, which can be associated with TMA. So she had been on bortezomib prior, even though the carfilzomib was relatively new, but she'd been on it prior also, yeah.
Also, I think it's really interesting that she had an auto transplant in the history, and it wasn't that long ago. And so it may have been that she was sort of sensitized by having the preparatory drugs for that transplant, which is usually what tips off the TMA. And they just, or maybe they didn't see it because they're cytopenic, and, so you have to really look for it.
You have a question there again.
So just a question about that. This is something that that we discuss quite frequently. Is autologous stem cell transplantation associated with TMA, or is it only allogenic? Because we think it is a
Yeah,
kind
so
of
no, it's
endothelial,
auto. So it's-
GVH disease. Actually.
Yeah, so it's really interesting because in Zandra Jodel's data, her first publication had 6 kids, 3 of whom had auto, 3 of whom had allo. So it wasn't the tacrolimus or the sirolimus that they gave for the GVH. It was the transplant prep. They use thiotepa. It's pretty noxious. So I would think and we've seen it with allos as well as autos.
I mean, if I had 10 patients, and I would say 9 out of the 10 would be allo. I've seen 1 or 2 with the auto as well. It's possible that this patient might have had auto-induced chronic TMA, and then the carfilzomib might have triggered the second.
Yeah, because I agree with the comment that was made earlier. The MPGN pattern bothers me for this to be an acute drug-related event solely. You've convinced me that it probably is drug-related, but that the MPGN pattern does bother me. So if it is drug-related, would this patient have gotten better without the eculizumab?
We don't know.
Good question. I'll show you some data later about that.
Does she have the luxury of time to just sit and watch? That's the question. That's the problem with cancer-related TMA. These patients can go south really fast.
Historically, we have not had very good success at all with eculizumab. So I suspect this patient had ATN and it probably got better, but I'm sure the speaker will show us more information. The biopsy was a couple of weeks after treatment? Is that correct?
After the eculizumab, yeah. Because I think the concern was whether this was truly drug-related or not. Even though by the time she got the biopsy, her kidney function had sort of improved to a great extent, and her platelets had they were about 70, 80,000. It was more to sort of prognostic and figure out what the future treatment would be for her. It was more for that.
That makes sense.
Whether
Okay.
she would be eligible for proteasome inhibitors or not, and what exactly is going on with the kidney.
Okay, perfect. Thank you. So the reduplication of the basement membrane makes it unlikely that it was something that happened just 2 weeks ago or a
Right,
week
I
ago,
agree.
right? So-
I think it was a little bit longer for sure. I think her presentation was a little out of proportion to this, yeah.
Just wondering if there is a way to test the paraprotein, if they can interfere with the alternative complement pathway, the same way the C3G do, but because this bind to the tissue, it might really do this, interfere with the solid phase. So if we just fractionated it out and run a functional assay, we might be able to answer this question.
Yeah, I don't know, maybe.
Yeah, we've actually looked at that question several times, and it's very difficult to do that. But in about 25% of patients, we can show that if they present with MGERS, we can show that the paraprotein has an effect on the alternative pathway. But that takes a lot of work.
Okay. And then I guess we come to the same question. How long should she be treated with eculizumab, and can she be re-challenged with the carfilzomib?
Do you want me to present, and then Kelly might?
We want to maybe see what the
Let's
audience
see what the
thinks.
audience.
Do you think you'll re-challenge this patient with the drug? I mean, we've discussed she had chronic changes. The drug was maybe not the sole cause, but maybe adding some factor. I don't know.
Can you do both together? So I think if...
Someone said they want to do both together.
Okay.
Well, if she was responding to carfilzomib, I will continue with the eculizumab.
So that's what you said, right, Gargi? That she's responding, give her the carfil and add ECU. Okay. Any other thoughts? Okay, all right. So what?
Genetic testing, anybody wants to do genetic testing? Yeah. Hers was done, it was negative, but yeah.
We always do genetic.
We always do.
All
Well, you
right.
never know what you're going to find.
That is true. That is fine. All
And-
right. Kenar, go for it.
And chances are 6 out of 10 are going to have a mutation of some kind.
So just on this case, I'll talk 2-3 minutes on cancer drug-induced TMA, and then we'll go to the second case, and Ilene will do a summary at the end. So as you probably are aware, there are 2 types of cancer drug-induced TMA, the direct toxicity that you see with endothelial injury directly and maybe time-dependent and dose-dependent. And the one that we see immune-mediated, the classic one, is the quinine. That's non-dose related, and that has formed antibodies and cause TMA. So both these are listed here, sort of what you see. Now, we have the first author sitting there, Dr. Kalamjit. So I'm presenting his paper that was just published. A lot of us thought that the most common cancer agent to cause TMA was Avastin or bevacizumab or gemcitabine. So using information component that basically removes all the noise and a very complicated statistical analysis that Kalamjit comes up with, we were able to figure out the adverse reaction of TMA with which neoplastic agent. And this was in the large database of Vigibase, which is a European database. It turns out carfilzomib has the highest IC25 for all TMA studied, followed by gemcitabine, mitomycin, bevacizumab, and bortezomib. Okay. Interestingly, the TMA happened overall in 122 days, and median time of onset was the shortest for proteasome inhibitors, fitting our case, and the longest in gemcitabine and mitomycin. And a lot of them did recover. The ones that did not recover more likely were related to checkpoint inhibitor related TMA. So the rate of recovery with proteasome inhibitors was probably the best at 85.8%. Again, fitting very similar to our case. And then it went down a little bit, but the worst was, again, checkpoint inhibitor, which is still very rare. Fatality, again, was the highest for checkpoint inhibitor TMA, and the lowest for gemcitabine, mitomycin. Again, management is anyone's guess. It's probably stopping the drug. We will freeze a lot of times because we just don't know at that time what is the cause of the TMA. So like we did in this patient, we're not sure if this is TTP. We're not sure, are we removing some inhibitor? So it's worth trying. It's Friday night always, usually. And then you decide by Monday. And then the question becomes anti-complement therapy. So, this is giving of eculizumab. What is the literature? The literature mostly comes from case series and retrospective studies from gemcitabine and bevacizumab. These two studies basically showed in small case series that giving eculizumab did improve kidney function and hematologic parameters, and one large study, which is 12 patients large, did improve partial remission in 67% with bevacizumab, or gemcitabine-induced TMA. And I take you to this case report and KI reports by Effie et al. They actually did something similar to someone in the back there suggested, where they gave gemcitabine, simultaneously with eculizumab as a re-challenge once they had figured out it was from gemcitabine. But in that paper, they do summarize some of the outcomes of gemcitabine-induced, treatment of gemcitabine-induced TMA with eculizumab with varied improvement, but mostly improved in most cases. And again, like I said, there was no data to support either way. Could we give this offending agent with the use of eculizumab along with it? And this is the only data I could find. And that last case over there, they actually were able to give re-challenge with gemcitabine along with eculizumab, but the patient eventually succumbed to the cancer. And in terms of giving re-challenge with carfilzomib, I don't know much of any data. I don't know if you guys have any data on re-challenge of carfilzomib along with eculizumab. I couldn't find anything specific in that realm. So it's possible we could do it. I just want to bring people's attention. Do we need the complement pathway to fight the cancer? I'm assuming we do. Blocking it, are we doing harm? This patient is on the last line of chemo. So just putting it out there for discussion.
We did have one question from the virtual audience asking or saying they didn't think they would re-challenge the patient. They think they would re-challenge the patient. They're asking, what about using DARA and an oral proteasome inhibitor? Using daratumumab and an oral proteasome inhibitor, but not re-challenge with carfil.
So I think this patient has not been re-challenged, even though the genetic, everything came back negative. The plan is to continue with the DARA. And I'm not sure what, in terms of the other drug, they're not still clear, but they're not good. I know that the hematologists weren't planning on giving her back the carfilzomib, at least so far. I know there was this study that was published, I think a couple of years ago. I believe it's a German study wherein they actually looked at the genomic mutations in patients. It was a small study, 10 patients with carfilzomib-associated TMA versus myeloma patients who got the carfilzomib and did not develop TMA. And I know in that there were 2 patients that were re-challenged with bortezomib, and they did fine. I mean, again, the follow-up was short, so it wasn't that just the whole class of drug is contraindicated. I mean, it's very limited numbers. I don't think we know enough. I don't think the follow-up is there, but at least in those cases, they did okay once the switch was made.
So they went switch from carfilzomib to bortezomib?
Yes, yes.
Sorry, lots of newer like narsoplimab and the factor B, factor D blockers. Any experience, has anybody tried? In this patient, was the alternate pathway activated, not activated? I know there was a measurement.
So it was done a couple of days after the eculizumab. There was elevation of the membrane attack MAC was a little bit high, but it was after the eculizumab, and there was suppression of the alternate pathway.
Which you would
but again, it was on the drug.
Yeah. You would expect that on ECU.
Yeah, it was on the drug, so.
Yeah. Right.
Okay. So I'll go to the second case. This is a 67-year-old woman with history of CLL and cryoglobulinemia who presented to the outside hospital with nausea, vomiting, and diarrhea. She had been sick for a few weeks with fever, decreased appetite, chills, itching, and diarrhea. And she had recently changed her treatment to venetoclax, which is a BCL2 inhibitor. And she had originally, for the last couple of years, been on acalabrutinib, which is a Bruton kinase inhibitor. So when she presented to the outside hospital, she was hyponatremic with a sodium of 117 with AKI and a creatinine of 4.7. She was also noted to be anemic and thrombocytopenic. Her UA had a lot of blood as well as protein. And while she was at the outside hospital, they thought maybe some of it was just pre-renal. They gave her some fluids. She didn't get better. She was started on dialysis. There was a concern, given the hematuria and the proteinuria, that she might have some sort of an underlying glomerulonephritis. So she was started on high-dose steroids for 3 days. But she developed acute vision loss in the setting of uncontrolled hypertension. She had MRI findings which were consistent with PRESS. She was eventually managed just conservatively with blood pressure control, and then she underwent a kidney biopsy, and she was transferred to our hospital. Just a little bit about her cancer history. She was diagnosed with CLL in 2009, at which time she had been monitored for 10 years with no treatment. In 2019, she did develop AKI with nephrotic range proteinuria of 8 grams. She had an immunofixation which showed IgG lambda with a slightly suppressed kappa lambda ratio of 0.16. She had a bone marrow biopsy which was consistent with a small lymphocytic lymphoma, CLL. She underwent a kidney biopsy at that time, and she had a monoclonal immunoglobulin deposition disease with IgG lambda specificity, MPGN pattern, with nodular pattern of glomerular injury. And that time she received treatment with obinutuzumab. But then because of the pandemic, that was stopped, and she was in complete remission. And then in 2021, she had been on acalabrutinib, and recently, basically, she had been changed to venetoclax just about a couple of months prior to her admission. And this is a physical exam, nothing, just a little hypertensive, but other than that, there was nothing pertinent. And these are her labs when she came to us. She was anemic. She was still anemic. Hemoglobin was 8, platelets was 70. Obviously, she was dialysis dependent at this point, so the creatinine was 5. Her LDH was marginal, 362. Her hapto was still less than 20. And her stool was also positive for enteropathogenic, not Shiga toxin. Her complements were suppressed. Her C3 was 53, C4 was 2. We did the immunofixation. She still had the IgG lambda. Her kappa lambda ratio was about 0.04. In 2019, at the time when she had the kidney biopsy, it was about 0.16, just for reference. And then we checked her serum cryoglobulins, but they, for whatever reason, weren't reportable in our hospital due to some lipemic sample, but they had been positive at the outside hospital. Her UA continued to show a lot of blood and protein, and she had about 2.5 grams of protein. So we did do a kidney biopsy. What do you think the pathology will show?
And this is a prize question.
It's a prize question, apparently.
So she's had a biopsy in 2019, and now she comes in with this, and she's been completely fine in between up until this treatment was started.
He wants to try.
Right. Nobody's diagnosed with these.
So what is the white blood cell?
It was okay, like about 5,000 or so.
Okay. So this patient has CLL and presented with, it's looked like nephritic syndrome. So, there are several pathology that you could find in patient with CLL when you do a kidney biopsy. Actually, the most common pathology you see, there's a study published from the Mayo Clinic. They found that the most common pathology is an MPGN pattern of injury, and the most common of that is a cryo. So this patient has cryo, so possibly they may have a cryo, deposit in the kidneys. Given the fact that the patient has monoclonal protein, the patient could have, and also what we find in the blood right now, the patient can have evidence of endothelial injury. The patients may have evidence of chronic TMA, double contouring or endothelial swelling, etc. The other thing that I am thinking is it could be the patient may have the CLL, infiltration, because actually that's the second most common renal pathology in this, CLL patient. Now the other thing I was thinking, which I'm not sure we're gonna see is that the depositions of the monoclonal protein, they could have relapsed, but because of the lambda is increasing, so
out of the 4.
I mean,
come up with
if you ask me, TMA.
You summarized
But
the whole
we have
paper.
to be open-minded.
It's a TMA conference.
I think that's an excellent summary.
That is an excellent summary.
And I think it's possible they'll all be present, but I'm going to vote for MPGN, and because the C4 is so very low, cryos are going to be present there. You're going to see them on light and EM.
Any other takers? All right, you want to pick one?
Oh, I got it.
No. You want to pick one out.
Diagnosis.
You want to pick one out of your 4.
Our 4.
Why don't you pick one or two?
TMA.
You're going to go with TMA. All right.
So, do you want to specify? You think it's all going to be chronic or acute?
Acute on chronic. Which is, to be honest, this is what.
Are you a pathologist?
To be honest, this is the most common, report that I've seen so far from the renal pathology.
All right. I mean, so
Let's hear the biopsy, then
let's
we
see.
can decide.
So
The audience can decide
this
if he
is
gets
the
it or not.
biopsy. So you can see endocapillary thrombi with arteriolar thrombus. This is just showing that it was all positive for fibrin. There was some monoclonality with lambda being more positive than kappa. And there was evidence of double contouring on electron microscopy. So she did have acute and chronic TMA with abundant fibrin thrombi, acute tubular injury, likely secondary to above, IgG lambda monoclonal immunoglobulin deposition disease with focal features of MPGN with moderate arteriolar hyalinosis and some mild IFTA. So
There was no cryo.
there was no cryo. No, there was no cryo. And just a reminder, in 2019 also, her biopsy had shown the same monoclonal immunoglobulin deposition with IgG lambda specificity, membranoproliferative, and a nodular pattern of glomerular injury. So what do we think her TMA is related to? I mean, so 2019, she did not have the TMA. 2023, she has the TMA. Her CLL has sort of actually been okay. Yeah. So what do we think it's related to? Is it related to her underlying CLL? Is it related to an infection-associated TMA, a complement-mediated TMA, immune complex, or drug-induced? It's like all, okay. All right, so
Wow.
we've covered everything. So most people are thinking that this is probably drug-induced.
Yeah, we can wait a few more seconds.
Okay. It's still, most people think it's
It's drug-induced.
drug-induced. Has it been described? Venetoclax-associated TMA? We're diagnosing it here. This is a case report.
I mean, I haven't
No.
heard of that. I mean, I haven't seen
We
or
haven't
read a
seen-
case. Usually it's again tumor lysis syndrome with venetoclax when you up titrate the dose, but you can speak more.
I haven't seen it.
I haven't
Yeah.
seen it either, yeah.
Well, if you look in Hippocrates,
Okay.
it is associated with thrombocytopenia and hemolytic anemia. And so, I
But they don't really
I
define
don't know whether
that.
that qualifies for a TMA, but it's getting close.
It's getting, and there's
And
AKI
renal
from
failure.
TLS. Yeah, AKI from TLS. Okay. So how would you treat this patient? Would you start on a complement inhibitor, eculizumab? Would you pherese? Would you just, switch treatment and go back to what had been treated in the past? would you repeat a bone marrow and then decide on the CLL treatment, or would you treat the underlying infection and just say that, let's just wait and watch, this is less likely to be related to CLL? So we would, okay.
So nobody thinks there's an underlying infection and this is not CLL related. Nobody wants to freeze the patient. There are 8 for ECU, 6 for aggressive treatment of CLL, 2 for repeat bone marrow, and decide to treat CLL after that. ECU is winning right now.
So I guess we do think, so there are a fair number of people who think that this is perhaps related to CLL then, right? I mean, that it's not really drug-induced, it's probably the underlying. Okay,
And
CLL.
the ECU is, what is everybody thinking? Whoever answered ECU, what are your thoughts? Is it coming from the virtual audience?
Well, you could argue that she had evidence of TMA within the biopsy. So you have to, you can't ignore that. You did the biopsy, it gave you the information. So you do need to think about that. I think it was really interesting that there was more arterial stuff than there was less consistent with AHUS than with something like TTP, where you'd see more platelet aggregate arterial events, but it doesn't rule it out. So I think, the issue is, do you think this was drug-induced? Or if you don't think, because it was relatively short after starting the drug, if you think it's drug-induced, and you feel you need to continue the drug,
then you would use it.
Then I would think you could give ECU in that setting.
Given the fact that we don't even have that option of stopping the drug, I think that was not even in the differential, right?
Right.
Okay, all right, let's see.
So I'll tell you what we did. We felt that this was really related to her underlying CLL because she had had this, she had had AKI with some light chain deposition even way back in 2019. We couldn't explain why she would have an acute TMA for this presentation when all in all there wasn't that much of a change. But our feeling was that her CLL needed to be treated better and perhaps go back to what she had been originally on, which was acalabrutinib or even obinutuzumab, which she had previously. We did think that, with her complements being low, with this whole acute TMA, we did start her on treatment with eculizumab, but we spoke to hematology. They weren't really that convinced initially, but they decided to, biopsy her, and obviously the biopsy isn't that, the bone marrow isn't that different, but they have now started her on the Bruton kinase inhibitor, and she was on dialysis for almost a month, but now she's finally, recovering some kidney function, and her most recent creatinine is 1.8. So
it was still unclear to me, Rimda, why was initially when she was on the obitumab, right? Why was that even changed?
Because during the pandemic, I think it was more of they didn't want to treat her at that time because first of all, she had gone into complete remission, complete resolution of the proteinuria, complete normalization of the kidney function, and there was this whole thing that her CLL had been really stable. It was more the renal manifestations, and then everything was sort of stable. We're in the midst of a pandemic, so they decided to just
stop it off at that point.
And then they started her on in 2021, though. But
so
just
that was
for
3 years later?
So 2019 she has this, and in 2020 she gets nothing.
And okay.
I think, she gets about 3 doses of obinutuzumab, but in 2021 she starts this. So she hadn't been off treatment for that long, though.
But why did they switch her from the Bruton kinase inhibitor to venetoclax?
Yeah. And I think, Dr. Weitz, you can speak of this, but what I was told was that when you're on a Bruton kinase inhibitor, you're sort of on it indefinitely.
Forever.
But When you're on venetoclax, you can actually, if CLL is stable, you can eventually stop the drug.
Yeah, I think that was probably their thing.
Yeah,
Yeah,
that's what I was told.
And why is that? Why does a person on Bruton kinase have to stay on it indefinitely?
Because the disease comes right back otherwise.
So that's what happened.
Yeah.
So why is that used to begin with? Why?
Because it's very effective. It is very effective, and it's so, especially acalabrutinib, so easy to tolerate.
Yeah, she was
Yeah.
doing very well with it, and I
Yeah.
think when the
Yeah.
switch happened, that's when she.
Yeah.
I guess a question for the hematologist is what is the underlying rate of somatic hypermutation in CLL? Because we do give this clone genetic pressure with ominituzumab to select some of the clone out, and the remaining one might have been in a pressure to actually mutate their antibodies. That's why this, fluid phase inhibition was acquired. Because in the usual nephrology thinking, what I was taught is that when a plasma cell clone usually present in the beginning, if there's MIDD, it will be MIDD. The physiochemical property usually doesn't change. If they relapse, it relapses the same. But here, the physiochemical property seems to have changed, and perhaps one possibility is this somatic hypermutation. So I'm not sure what's the biology of CLL.
I don't know how to answer that. What did change was she no longer had the cryoglobulins. And so whatever the CLL was producing, that got suppressed. And sometimes as the disease progresses, you see a decrease in what's being produced because they do kind of mutate. So that's conceivable. Or it's also possible they just didn't do a good study, which is easy with cryoglobulins. I mean, half the time they come back negative. So I don't know the right answer to that.
Oh, and Joan has a question.
I'm sorry, I'm still thinking actually about the cryo-GN. When we look to the H&E stain, the thrombi were pretty eosinophilic, too much for a normal TMA, in my opinion at least. Do we have information about the PAS stain? Was it PAS positive, which is more like a cryoglobulinemic deposit intracapillary? Did you see on electron microscopy a thrombus that is not like a cryoglobulinemic feature, as said before? And the fibrin deposits were in the arterioles. The patient presented with a breast-like lesion or breast-like syndrome, and that can be hypertension related in the pre-glomerular area, actually. Did you also see the fibrin deposits in your glomeruli?
Yes.
Use the mic.
Oh, so I'm sorry. Actually, I think I might have missed your question. But is it that on electron microscopy, whether it was the fibrin deposits, whether we saw that versus cryo? Is that what the question is?
That was one of the questions,
Yes,
yeah.
yeah.
As well
Yes.
as the immunofluorescence. Do you have a, well, I'm still not sure that it's a fibrin thrombus, actually. So the question is, do you see in the glomeruli fibrin staining in immunofluorescence microscopy? And after that, do you see in electron microscopy typical features of a fibrin thrombus? Or is it more like a cryoglobulinemic thrombus, or don't you see a thrombus at all?
No, so on electron microscopy, the fibrils that were seen were of the same size that were consistent with fibrin fibrils rather than cryo. Yeah.
Then it's clear. Thank you.
Yes.
Personally, I would just treat the CLL, so it shouldn't really matter what you see in the EM. I mean, it's a good thing. I like pathologists describe these things, but if it's secondary to something, just treat the something. And here at CLL, this is what I think one of the audience members had mentioned, that the most common pathology seen in the kidney is MPGN pattern of injury. But remember, some of these studies were done way before we described the new MPGN classification, which includes TMA, if it's immunofluorescence negative. So who knows if some of those MPGN could be TMA. But like Kalamji had mentioned, most of these are cryo. And then AL amyloid actually is also fairly common with CLL. But in terms of TMA, immunotactoid is one that you should keep in mind. If you get a diagnosis of immunotactoid, look for CLL, the other way around. But TMA and CLL, I could only find one paper that really described a relatively large series of 6 patients. And that's pretty much it that's been described out there. And 4 of those actually got treatment for CLL. And the TMA slightly got better. One of them actually had another cancer that was involved. They did have presence of systemic or renal TMA. So really, that's the literature out there. So I think high index of suspicion is important with such cases. And if it fits with the underlying hematologic malignancy, treating that might just be the best option. It's also possible that drugs like obinutuzumab and tyrosine kinase inhibitors are treating an autoimmune disease that we haven't diagnosed in this patient, because those drugs do get used for autoimmune diseases. So we're just putting it out there. We might have serendipitously treated maybe some other autoimmune disease. And I'll hand it over to
Okay, so, I'm sort of a dinosaur, and I remember when mitomycin was one of the few drugs we actually had to use. And it was so toxic that it had been replaced. But now it's come back, particularly in the GU literature. So it'll be interesting to see if we see more and more mitomycin toxicity. But if you look at cancers and you look at the role of complement in cancers, it's a very complicated affair. Complement can lyse a tumor cell. It can also act as a tumor suppressor, and it can induce membrane vesiculation, which can then go on to provoke thrombosis, and provoke DIC, for example. It may be the increased risk of thrombosis that we see in cancer, one of the things that occurs. It can act as a tumor promoter because it interacts with angiogenesis by interacting with this response gene to complement 32. C5b9 complexes are inserted into the endothelial membranes and can stimulate these G proteins, and it can promote vascular neointimal formation and smooth muscle proliferation. As early as the 1970s, and I remember this from when I was a medical student and a resident, that gastric cancers were associated with TMAs. And it was usually mucinous gastric cancers. Cobalamin deficiency can be seen with gastric cancers, and so it may cause a TMA-like syndrome, which may be a contributing factor. But platelet-derived growth factor A, vascular endothelial growth factor C, secreted by the tumor cells, can induce further endothelial damage, and tumor embolization, particularly with gastric cancers, can cause pulmonary TMA. And this particular syndrome is rapidly progressing. You get pulmonary decompensation. I hadn't seen it for a really long time, and then we got a consult from one of our oncologists, and they had a patient who had this. And the patient died within a few weeks. The chest x-ray usually shows ground glass appearance without infectious etiology, and the pathologic findings are small vessel arterial occlusion, intimal proliferation, and fibrin deposition. And here you can see the chest x-ray and the assorted vascular findings that you can see with the deposition of C5b9 complexes. Now, what about chemotherapy-induced TMA? So we treat the patients, and again, mitomycin is the classic for TMA-inducing chemotherapy. It usually occurs as a result of cumulative dosing, and you see the onset of renal failure 4 to 8 weeks after the last dose of the mitomycin is given. It can occur anywhere from 6 to 12 months after the last dose, and the cumulative dose is 40 to 60 milligrams. The seminal presentation is an acute development of acute non-cardiogenic pulmonary edema. And that's something that you don't see with TTP. Renal failure is very prominent and it's irreversible, and the response to plasma exchange is dismal. And so being aware of the cumulative dosing is critical in mitomycin. Gemcitabine, on the other hand, is also induced cumulative toxicity, but usually presents about 6 to 8 months after treatment with a total dose of 22.5 milligrams plus or minus. In contrast to mitomycin, the renal insufficiency is the hallmark presentation of gemcitabine TMA. And 2/3 of the patients will present with the onset or worsening systemic hypertension. Again, when you get TMA, you get endothelial injury, and hypertension is very common. They get microscopic hematuria and proteinuria. On the path, you'll see capillary walls, thickening, fine fibrin thrombi, necrotic endothelial cells. C3 deposition is evident on renal biopsy. Again, response to plasma exchange is terrible. And there are some recent reports of these patients reversing with complement inhibitors. A treatment with anti-VEGF inhibitors, bevacizumab, tyrosine kinase inhibitors, have all been associated with an AHUS-like syndrome. Virtually all the chemotherapeutic agents will present with an HUS-like syndrome. We rarely see anything suggesting TTP. But there is a differential effect on the kidney with anti-VEGF therapy. You could see these, we keep seeing these intraglomerular thrombotic microangiopathy, which is more common with the ligand inhibitors compared to a TKI. TKIs cause more damage to the podocytes, like minimal change nephropathy or collapsing focal glomerular sclerosis. And the focal glomerular capillary microaneurysms can be seen, and hyalinosis are typical features of anti-VEGF therapy, including glomerular microangiopathy, whereas the fibrin and the platelet thrombi are rarely found or are absent. In a published series of patients with chemotherapy-induced TMA, all the patients failed drug cessation and PECs. And a complete response was achieved with complement inhibition, really signaling that there is a role for complement activation in this order. These patients had short-term therapy, 12 to 24 weeks. That appeared to be enough to ameliorate the disorder, and it appears to be effective in a variety of different chemotherapeutic therapies. And interestingly enough, so this was an interesting paper where they looked at continuing C5 inhibition and ongoing treatment because they didn't want to stop that therapy. And so, and if you look at the paper that Tom DeLaury and I did, one of the patients received ongoing chemo for another 6 months and is alive today. All our patients are alive. They all had short-term therapy. The Hopkins data also suggests that you can continue therapy and treat the patient. So TMA is an important cause of cancer-related morbidity, mortality. TMA in cancer can be due to the tumor characteristics. Pulmonary TMA is rapidly fatal and rapidly progressive. Hypertension is a harbinger, and cumulative dosing is important. And complement inhibition appears to be effective in chemotherapy-related TMA, and as well as transplant-related TMA. And I think it's almost time for a break, and I'll say thanks.
Thank you, Dr. Weitz, Dr. Jhaveri, Dr. Wanchoo. Any comments, questions for the two cases? Any questions for the panelist, speaker?
I have a question regarding the hematologist. The liver injury we see in HELP, and in SOS post-stem cell transplant. Is that just TMA in the liver?
That's interesting, because I don't think anybody's biopsied those livers. But I think that in transplant-related TMA, it's certainly a possibility.
Mm-hmm. You're talking about stem cell transplant,
Yeah.
bone marrow
Yeah.
transplant, yeah.
There's one question. Is there a role for more proximal inhibition of complement pathway factor B inhibitors?
In any particular situation? What are
Well,
the-
let's say in cancer-related or
TMS?
chemotherapy-related, probably, I mean, there's some evidence, I mean, it may be that this is alternative pathway mediated, maybe. It may also be, we know that the lectin pathway is involved, so maybe treating higher up may have a role. There is no data that I'm aware of. I mean, it's intriguing because they're oral agents, they're quick, they're fast-acting, so might be something that might have a role, but at the moment, there's no data.
I guess one other question or comment tacking on to your point, Dr. Jhaveri, but what about idiopathic pneumonia syndrome in the post-stem cell transplant population, and could that be pulmonary TMA?
Yeah, it's possible, the transplanters don't call for help very often, which is probably something they should do more often. But they're very focused on what they have, and they have their ways of treating it. But it's possible, and things like, TTP rarely involves the lungs. You don't see the lungs involved. The lungs are a low-flow system, and you don't stretch out your ADAM-TS13, and you don't stretch out your von Willebrand factor, any of that stuff. So but it's intriguing that it might, but they don't usually go there. And part of the reason they don't want to go there is they don't want, once they diagnose a TMA, they have to do something about it. Well, I quite honestly, I get into these fights all the time. But I mean, it's true. I mean, you did the test for a reason. And if you found something, then you need to act on the test or don't do the test. Okay? And so if you find TMA, then you should act on the fact that there's a TMA. And that might require an expensive drug.
All right, so we have planned for a 30-minute coffee break, which we are going to skip, but there's coffee in the back if you guys want to get up, just move your legs around.